Welcome to Respiratory Emergencies. Dyspnea, the Latin term for difficulty breathing, is a complaint that we really run to on a regular basis in EMS, probably only rivaled by the general sick call in regards to a true medical complaint. It can rarely have any kind of cause to it, from a common cold to straight up CHF heart failure, and there's a plethora of things that can be causations in between that. So some of the things that you need to do is be really consistent with your ability to take the history of the patient, both the past medical history and the history of present illness, because more often than not, the past medical history will tell you what you can and cannot rule in or out of the patient's general complaint right now. Try to always remember that your patient is experiencing the sensation of suffocation. And many people find that to be one of the more terrifying things that can happen. The thoughts or being frightened of drowning or claustrophobia, just due to that very similar sensation of feeling the inability to breathe. So this could be a very heavy psychological component during your treatment and assessment. So the respiratory system is comprised of several components, most of them belonging either to the upper or the lower airway. And by that I mean we're talking about the nasopharynx, oropharynx, and everything basically from the trachea up, and then from the trachea down being the lower airway, where we get into the bronchioles and into the actual lung tissue with the alveolar membranes and the circulatory system that surrounds all of that tissue. When we breathe, the air or the atmosphere enters the upper airway primarily through the nose. That's traditionally how most adults breathe, as nasal breathers, and that's because there's a filtration, moistening, and warming act that happens as air rushes through the nasal cavity into the oropharynx and then actually into the lungs. What we want to do is filter any of the debris out of that air. We want to make sure that it's getting warmed up to as close as possible to body temperature, and that it's being moistened from the mucous membranes. What we don't want to do is have air that's rushing into the lungs, and because it's cold or dry or even hot and dry, it actually pulling moisture out of the lung tissue, which would cause a dehydration factor that would be significantly more than it already is. So the act of respiration, according to definition, is the cellular ability to onload and offload oxygen and carbon dioxide. And for us, the ventilation, the mechanical part, right, unlike this slide, is the process of inspiration, which is taking the breath in, and then expiration, which is the exhalation or the breath out. Oxygen is provided to the blood and carbon dioxide gets removed from it. And this gas exchange happens because of diffusion. So if you guys remember when we went through diffusion, and we've touched on it several times, everything in nature wants to balance. So if there's a surplus of oxygen molecules inside the alveolar pockets, the oxygen is going to want to push across that membrane for diffusion to balance on both sides. So the red blood cells are going to have equal pressure of oxygen, and then carbon dioxide is going to want to push into the lung pockets, into the alveolar spaces, so that it can be moved off of the blood cells and then exhaled out. This is another slide of cellular respiration, and this is showing you how that gas exchange is happening in the alveolar membranes. If you're looking at the alveoli, you can see a massive cluster or network of capillaries, some of them being deoxygenated and some of them being oxygenated, obviously based on the flow path of blood. And as you can see, the lung tissue has heavy vasculature. It is one of the most vascular organs in the body because it has so much to do with perfusion. If you look at the lower picture, you can actually see where the red blood cells are passing that oxygen off to a regular cell, and then that cell is now, again, by diffusion, if it has a lower concentration of oxygen coming towards it, it will let oxygen pass into the cell. And then as a result, the higher concentration of CO2 in the cell is going to offload onto the lower concentration of carbon dioxide on a red blood cell. So this again is that diffusion principle, and the more that you guys understand how diffusion works, and it's really kind of a simple process, it's all about balance. Just try to remember that almost everything wants to maintain homeostasis or balance. So these are the mechanical or physiological stops for inspiration and expiration. And on inspiration, the stimulus comes from the respiratory center and the medulla. Think about the pons and things like that. The involuntary control of breathing originates in that brainstem, and then the diaphragm is the primary muscle controlling inspiration. So remember that the diaphragm separates the thoracic cavity from the abdominal cavity, with a small opening that allows the two major vessels and then the GI tract to kind of get through it. What we want to remember is that when the diaphragm contracts, it pulls down away from the rib cage, and that creates a lesser pressure than what's in the atmosphere. This allows room atmosphere to actually push into the lungs, and it is an active process, whereas expiration is very passive. It's just the relaxation of most of the muscle tissue, and we let the weight of the chest actually help to expire that gas back into the room. So on this slide, it's saying as the chest expands, mechanical receptors send a signal to inhibit the respiratory center. So it's basically like a stretch-like reflex. As the chest expands, it says we're at max capacity, and it shuts the drive down to continue to contract the diaphragm. That's the Herring-Brewer reflex, and it terminates inhalation so that we don't overexpand the lungs. So we're going to go back to the pathophysiology, and what we want you to remember is that ventilation and respiration are related, right? The mechanical act of ventilation requires diffusion so that there can be respiration at the lung tissue, and then we're going to have respiration again at the cellular level, which is what's basically causing perfusion, right? The only thing that we're missing in this particular chapter is the nutrition that's coming along the ride, or I should say coming along for the ride with the oxygen. We're always trying to get sugar into the cells, so that is one of those things that we're leaving kind of out of the loop here, because this particular lecture is focused on respiratory emergencies. We need to make sure that you can understand that there are many, many ways that we can inhibit oxygen being uploaded to a cell, both at the red blood cell or in the tissue. Some of those complications can be an upper airway obstruction, a lower airway obstruction, chest wall impairment, and neurological control problems. And so we're going to dive into that. We're going to have a couple of examples as far as what these obstructions or impairments are. Some upper airway obstructions might be, for instance, maybe sinusitis, right? We're going to get into this into the very raw, simple kind of ideas, which would be the nasal passages being inflamed. We have an upper respiratory infection where we have that runny nose, and that's actually slowing our ability to breathe. Lower airway obstructions could be anything like asthma or bronchitis, where we have narrowing of the airways, and then there's some increased mucus production. The chest wall impairment could quite simply be trauma, where we have some broken ribs and somebody's unable to actually take that deep breath because of the paradoxical movement and the pain associated with taking that deep breath. In our neurologic component, we're talking about somebody with a brain injury where there's increased cerebral pressure, which would actually be causing that increased pressure on the brainstem, which is where the pons resides, interrupting that neurological control. This is a pretty quick flow path that you can go through if you're going to do a rapid assessment, and where you're kind of trying to figure out where these things are coming from and the associated signs and symptoms. You should probably know these things, and this should be something that you've committed to memory. And if you don't have it, it's a pretty good list to just kind of start brain priming yourself. And every time you go to a respiratory call, you should already try to figure out what might actually be causing this call, right? Very often are you going to ever run an adult who has croup. That's a infant, small child issue. And then very irregularly, I mean, if ever at all, are you going to run on a baby that has CHF, right? I mean, it's possible, but it's something very unlikely. So as you're going to that call and you're being primed with the information about who's calling and what their complaint is, these are triggers for you to think about why this is happening and how you're going to verify it. Okay, so now we're going to talk about carbon dioxide retention and hypoxic drive. In carbon dioxide retention, the levels of CO2 can rise in the bloodstream for various reasons. Somebody can become very acidotic for a plethora of reasons, including lung disease, the inability to have a respiratory drive due to drugs or various other causes or concerns. Production of too much carbon dioxide in the body is also something that can happen, but there's generally an underlying physical cause for why that's happening. In a chronic carbon dioxide retention patient, hypoxic drive is something that develops, and it stimulates their respiratory center. Instead of the requirement for oxygen to be there, the CO2 level is what's actually driving the respiratory pattern. And so in a very minute amount of cases, giving too much oxygen to the patients will actually decrease their respiratory drive, although I don't think that you're really going to see it in an emergent condition where you're as an EMS patient. This is something where we're going to take enough time that we can actually drop their CO2 levels, and then their respiratory drive will slow. Now, if you have your patient on end tidal, you can see this. They would actually start to slow their respiratory pattern down enough that the body would get to another level of CO2. So you would see them go from a normal respiratory pattern of say 12 to 20, or perhaps just a little bit slower, to something significantly slower, in effect trying to trigger the body to get it to take that next breath again by making the bloodstream and then resultantly the CO2 levels in the exhalation back to where it thinks is normal at that point. Now, all of this being said, you never want to withhold oxygen from a patient. Our ultimate goal is to try to have that patient between 90 and 94% on whatever that oxygen delivery is. So here's that word dyspnea again, right? Dyspnea is shortness of breath or difficulty breathing, and it can be caused by many different things. If the problem is severe and the brain is deprived of oxygen, chances are that person is going to become altered and they're unable to give you a complaint about why they are altered. So some of the things that may cause dyspnea or a low O2 saturation generally tend to be some kind of a block of some sort. So acute pulmonary edema, right? If we have the fluid inside the lung tissue in the alveolar pockets and it's causing an additional barrier for oxygen and carbon dioxide to kind of cross that membrane, right? The additional barrier is going to create that increased CO2 level because we can't offload it through the actual extra barrier, and then we can't get oxygen back into the red blood cells. The obstructions of the airways, this again is the narrowing of the airways, and then the increased mucus production. Mucus is a significant barrier for gases to exchange through. That includes asthma or allergic reactions. COPD is going to fall into that because COPD is basically almost everything except for asthma in so far as reactive airway disease. Now, COPD also comes with emphysema, which has a mechanical component on top of it as well, because the structures are changed, which are now creating even more of a difficulty getting the surface area to exchange the oxygen and carbon dioxide. Rib fractures, again, somebody's unwilling to take that breath because of pain, and then the use of CNS depressant drugs. And this could be anything from alcohol to barbiturates or the combination of both, as well as some of the opiates. So any of these things, especially put into a cocktail, can cause significant respiratory depression, which is going to cause the dyspnea. And if they're altered, they're not going to be able to tell you that they just can't breathe. So some of these causes of dyspnea are going to be, again, some more obstructions. So you got atelectasis, which is Latin for a collapsed lung. And then we have damaged alveoli, which is your emphysema patient, where they're missing large portions of alveoli. The air passage is being obstructed. This is simply just the chronic bronchitis or the anaphylaxis or the asthmatics, where they're having that mucus plug in an actual bronchiole. Blood flow is being obstructed to the lung, and this is somebody that has a PE, a pulmonary embolism, where they have a blood clot somewhere in the pulmonary artery side, and it's blocking a large portion of the lung tissue from actually getting blood flow to have that gas exchange. And then obviously we can get all the way into the pleural space being filled with air or excess fluid, which would be a pneumothorax or even say a pneumonia where there's a bunch of fluid outside of the lung tissue in the pleural pocket, causing even more pressure or kind of irritation or irritability or inflammation. And then we can have a hemopneumo, which is, say, a ruptured blood vessel in the lung tissue where there was damage and we're bleeding into the pleural space, which is now causing that lung to collapse. Now on this slide, it's saying because, or besides the shortness of breath, a patient may also report air hunger or chest tightness. I think the two kind of go hand in hand. If somebody is whooping when they're breathing, they may say that they still feel tight in the chest. They are having that sensation of the inability to breathe. It's that suffocating. And so one of those things is going to be anxiety driven, and they're going to feel that tightness. It's a common complaint in patients with cardiopulmonary disease. Again, we have somebody with CHF where they're very prone to having fluid back up into the lungs. And that is, again, a resulting cause by the heart being unable to actually push against the vascular resistance or the afterload, and then the kidneys kind of help facilitate the drive to actually create more pressure. And so the resulting action is that the heart kind of still yet again is unable to actually do its job, and then the excess fluid starts to back up into the lungs. Obviously, infectious diseases can cause dyspnea. The common cold will make you feel like you're having a difficult time breathing. Most people generally complain of difficulty breathing when they have flu or a cold or just simply bronchitis if it's bacterial or viral. I mean, any illness can create this if it's causing some kind of additional mucus production anywhere in the airway. Acute pulmonary edema, acute meaning right now. This is a short-term event, chronic being long duration over time. So most of your CHF patients are going to experience what we call CHF exacerbation, which is acute pulmonary edema. And that simply means that plasma is backing up into the lung tissue because the left side of the heart, the left ventricle, cannot pump against the systemic vascular resistance. And so when that fluid gets pushed across the capillaries back into the alveolar membranes, it's coming into the lung tissue and it's creating that additional barrier. If you're looking into the picture there, you can kind of see what they're trying to represent with a little bit of extra fluid. And again, oxygen really doesn't want to travel through that fluid and then get into the bloodstream effectively, which will cause that increase of CO2 because we're limiting the gas exchange on both sides due to diffusion. And this causes the patient to have that sensation of suffocation. Now, when you listen to that patient, you're actually going to hear the rales of the rhonchi or crackles, there's any manner of name that people will call adventitious lung sounds. But you're going to hear it, and you're going to hear little bubbles popping. And that's gas trying to make its way back and forth through that fluid. And that's how we know that we have a patient with acute pulmonary edema. Some of them may be so significant that you can actually hear this as soon as you walk into the room. They sound like they're breathing underwater, or that they're inhaling small amounts of water as they take a breath in, and then you can hear it significantly as they exhale as well. And as time goes on, when you're in the field, you'll actually become more adept at figuring out just how severe this is. But regardless of how severe you think it is, to the patient, it can always be that it feels like it's a life-threatening event right then and there. And we could be talking about something very minor or something very significant. A couple of the other causes for acute pulmonary edema could be toxic poisonings, trauma, or exposure to high altitude. And this could be something as simple as an inhalation injury or even a saltwater drowning, right? If a patient inhales something that has a little bit more sodium than the blood has for its sodium content, you'll actually draw water out of the blood or the plasma out of the bloodstream into the lung tissue, creating that flash pulmonary edema. They can quite literally start drowning on their own fluids. Now, some of your cardiogenic patients may present with signs of a cardiac emergency. They may actually be having another event, whether that be another AMI or some kind of arrhythmia. If they're non-cardiac, they may present with hypoxic episodes, shock or chest trauma, and then again that recent inhalation of toxic gases or maybe even a powder or an ascent to a high altitude, and then or all patients that are respiratory in nature should have some kind of presentation that has dyspnea, orthopnea, fatigue, and then reduced exercise capacity, and then pulmonary rales. Again, the terminology for adventitious lung sounds can vary from person to person to person. Just understand that if it doesn't sound like it's supposed to be there, that is an adventitious lung sound. Now, orthopnea and fatigue are basically going to be primarily tied to the fact that that person is dyspneic or they have dyspnea. If they're unable to perfuse tissue, they're really going to have the inability to actually create more movement, which is going to create more oxygen demand. So in this picture, we're talking about COPD, and this is what they call a common lung condition. And as patients get older in age, they tend to be more likely to have COPD, and that's just from the chronic exposure to things that are irritants in the lung tissue and the resulting long-term damage that from the many insults that they've experienced over time. And it's a slow process that takes quite a while to get there, but once you get there, it's irreversible. The airways become inflamed. We start to develop mucus and other secretions that are trying to ultimately protect that airway. The actual tissue starts to thicken up and become a little bit more rigid or less elastic. And then the pulmonary blood vessels start to suffer as a result. And when things become hypoxic over time, they actually atrophy or shrink away. And in some of these, you can see where the alveolar pocket has enlarged. And in the case of emphysema, the septal walls between the alveolar pockets will actually dissolve away due to an inflammation response. And that takes away, again, that surface area for us to get that gas exchange. We're going to touch on the fact that cigarette smoking is probably a no-no, and it generally is probably one of the most common causes for somebody to ultimately have COPD. And in significant COPD, that is a death sentence for your patient. That is more often than not going to be the reason that they ultimately end up dying. And so these things are chronic bronchitis, emphysema, and pneumonia. And if you have pneumonia once, twice, 3, 4, 5 times a year, right, this is a chronic condition, and it's the body actually really working hard to try to fight off all the infection that's coming up. The obstruction occurs in the bronchioles, and that's because of these excess fluids or the reduced capacity for gas exchange. And most patients who have COPD have many of the elements of chronic bronchitis or emphysema. And they can have both. I mean, they could ultimately have structural changes in the alveolar membranes as well as the chronic bronchitis components. More often than not, the emphysema was caused by an irritant inhaled that was trapped, and again, that inflammation response, and then the body responds by creating mucus and those inflammatory chemicals that actually dissolve away the tissue over time. So in this picture, we're looking at what we would deem a patient who is a classic COPDer, right? You can see that he's kind of got that barrel chest, and you can see he's positioned himself in such a manner that's creating a decreased work of breathing for him because he's supporting the muscle and the bone structures to allow the diaphragm to get easier inhalation phase, right? It's got less weight and less resistance. And so they tend to be thin with that barrel chest, right? And a lot of these people are really working hard to breathe. They're not going to spend a lot of time trying to eat large meals. You know, you'll see that these people are really concentrating on breathing being the primary drive to survive. They also have an increased metabolism because they are working so much harder just to maintain any kind of actual life.